This has been billed as scleroderma renal crisis. Well, that's partly true. There are several types of kidney involvements in scleroderma. The one that's called scleroderma renal crisis is probably the biggest catastrophe that can occur in the kidney. So I'm going to talk about several different kinds of involvements. Most of them are benign, meaning they won't go anywhere to injure you. So what I'm going to do is talk about kidney function in healthy individuals, contrast that to kidney function in individuals who have scleroderma. Then I'm going to talk about the clinical patterns. Clinical means laboratory, blood pressure, that kind of stuff. There is a dysfunction that occurs in about half the people with scleroderma that usually doesn't go anywhere bad, but it's mildly abnormal. I'll talk about that. So there's fairly good evidence that the kidney blood flow is reduced in scleroderma. Again, most of the time, this is not something that's going to bother you. It may bother the doctor, but it's not going to bother you. Essential type hypertension, protein in the urine, or proteinuria is the fancy term, and mildly elevated creatinine, which is a measure of kidney function that I'll talk about. Then I'll get down to renal crisis, and then there's a fairly new entity, inflammation of blood vessels in the kidney called vasculitis, and the final topic will be kidney transplant. All right, so let's start with healthy individuals. You may remember this from high school physiology. You have two kidneys. They're kidney bean shaped. They drain through ureters down into the bladder. All right, now the business end of what I'm going to talk about occurs near the surface of the kidney. Inside the kidney are kind of triangular shaped structures called the medulla. The outer layer is called the cortex, and the business end of kidney function occurs right at the border. And I'm going to talk about something called a glomerulus, and I'll get down to that in a minute. This is a diagram of the glomerulus. I'll show you a blown up picture of a glomerulus as we go along so you get some idea of what it actually looks like. It's a bunch of curlicue arteries inside a structure called the glomerulus. The outer part of that is a urine space. So you have arteries and you have a urine space. So let's take a cross section of an artery. So you have the wall and you have an internal lining, that's the light blue. And then you have red corpuscles inside. Now, the glomerulus also has a urine space. So here is kind of the space filled with urine. Now, how did it get there? Well, first we'll talk about the structure. There's the wall, and then there's the urine cavity. So the arteries live inside the glomerulus. So they're kind of inside there. So this is two diagrams showing basically the same thing. You have the arteries and you have the urine space, and the arteries are going to drain waste products into the urine space. So, blood, waste, and water enter through the artery into the kidney, that's the red one. Blood without waste or excess water leaves through a vein, and excess water and toxic substances get dumped into the urine. So you get rid of them every day. In fact, every time you go to the bathroom. So this is a very tiny structure, but this is what a glomerulus actually looks like. All these little tiny arteries, thin-walled structures that will leak waste products and liquid. Okay, so we're still talking about healthy individuals. So water and small molecules go into the urine cavity through pores, holes, kind of a sieve, into the urine space. So creatinine is a waste product. It's benign, comes from muscle metabolism. It doesn't hurt you if the level starts to go up in your bloodstream, it suggests that the kidneys are not functioning as well as they should to get rid of the waste products. Creatinine is a waste product. There are a lot of other proteins and other things that come out in the urine too, but we take advantage of creatinine, and I'll show you some more about that in a minute. So larger molecules, like the proteins, albumin being one, can't get out of the artery because the sieve won't let them. The pores are small enough, proteins can't get out, or not very much anyway. All right, so let's kind of shift gears and look at kidney function in people that have scleroderma. So we have the anatomy of the artery again, but it looks a little different than the other one. There's the wall and the thickened internal lining. So the lining thickens, and that leaves less space for the blood to get through, so blood doesn't come through like it should. And you have the red blood cells. All right, so we're going to look at what the blood vessels look like under a microscope. This is not unique to the kidney. All right, so the lower left, the yellow circle is the edge of the muscle part of an artery, and inside is what should be wide open. But it's got this light blue stuff in there. That's thickening of the wall. So it gets harder and harder for the blood to get through. So another artery in the kidney, I'm sorry, the one on the lower left was finger artery. The one in the upper left is the kidney, but it looks very similar. And then there's the pulmonary artery down in the right lower. Same thing, the lining thickens. And here's just another kidney shot. Well, the artery still lives inside the glomerulus, but it's not a normal artery. It's one that's got a narrowing of the canal. And small molecules like creatinine and water do get out, and in some cases, the larger molecules also get out. So there's the protein, and it leaks out because the pores have widened. They've gotten bigger, let more stuff out into the urine. All right, so chronic kidney dysfunction occurs about half the time, at least using fairly easy to use techniques. So we're going to talk about the dysfunction. Okay, so there's reduced kidney blood flow. And again, we have the thickening, the blue is the intima, the internal lining of the artery. So that's narrowed the canal. So normal blood flow would look like this. In scleroderma, it looks like this because not as much blood gets through and not as much gets filtered. Second manifestation can be what looks like essential type hypertension, which occurs about 10–11% in the general population and also in scleroderma. This is not an emergency. This needs to be treated, but it's not an emergency. Protein in the urine, so the small molecules get out there, and the larger molecules get out there. And finally, creatinine. Now this is the benign metabolite from muscle metabolism. We use it to see how well the kidney is filtering things. So the normal would be like the green. If the kidney doesn't filter as well, then creatinine begins to pile up in the blood and you get what looks like the yellow bar. Okay, so the concept of limited and diffuse is important when we're going to talk about kidney dysfunction. So limited is the mannequin on the left. Thickening doesn't happen above the elbow or above the knee or below the clavicle, ever. On the other side, the right side, is diffuse. That's involvement above the elbow, above the knee, and below the clavicles. So if you have thickening on your fingers and the forearms and your chest, that's diffuse. All right, so these are some frequencies of kidney abnormalities. This is Virginia Steen's large data bank. So she found what looks like essential hypertension, about the same in diffuse and limited. Protein actually is unusual in average. At her institution, they have used a lot of penicillamine, and that causes the kidney to leak protein as well. So when you correct for people who don't have penicillamine in their history ever, it's small, a couple percent. Elevated creatinine is about 15%. This doesn't mean you're going to go on to dialysis, just means your kidneys are not filtering like they did when you were 20.
My creatinine, I think,
I'm sorry?
my creatinine was 1.9 a couple weeks ago.
Okay.
It was like 1.5 like 6 months ago. Now it's gone up to 1.9. Could that be
Don't hold your breath yet.
Could dehydration have
Yep, can. Anything that shrinks the amount of fluid in your blood can cause the creatinine to go up. So, yes. Okay, so now we get to renal crisis. This is something that we don't take lightly because it is a catastrophe in many cases. And the definition hinges upon kidney failure. 90% of the time, people will have new onset high blood pressure. And it may be 150 over 90, or it could be 220 over 130, but it's new. And we take advantage of that sometimes when we see people early. We want them to take their pressures at home, and if it starts to go up, then they need to get on the phone and get treated. And we'll talk about the treatments as we go along here. Okay, so what actually happens, we have a pretty good idea of what happens. We don't know why it happens. There is a cellular structure. I've put a biscuit in there, but it's something called a Juxta-glomerular apparatus. It's at the entrance of the arteries into the glomerulus. That helps regulate pressure and fluids. And so from day to day, whether you're lying down, standing up, whether you've had a lot of water, no water, all these can make minor changes in what I will talk about here with something called renin and angiotensin. Okay, in scleroderma, there's for some reason a clot that forms at the entrance to the glomerulus in the artery. So blood can't get into the glomerulus. Okay, so when that happens, the kidney senses injury and it will release a substance called renin and also some other substances that lead to high blood pressure and kidney failure. Okay, so the blood clot reduces blood flow through the kidney even more so than just average. I mean, it's just an acute reduction. So renin is released, and another hormone called aldosterone is released that forces your body to hang on to sodium and water, and you begin to swell up. Renin converts a substance called angiotensinogen to angiotensin-I. I've got a diagram that will kind of outline this better, but at least you'll have heard the words. Angiotensin-I is activated by another hormone called angiotensin converting, or it's an enzyme actually, angiotensin converting enzyme to an active form called angiotensin-II. It's one of the strongest vasoconstrictors that our body makes. So everything clamps down when these levels are very high. So this is something that was photographed in the 1960s, probably never to be demonstrated again because dye in the presence of kidney failure just gums things up even worse. But on the left-hand side, you see this bush, all these little tiny vessels coming out to nourish the kidney. And on the right-hand side, you see a tree that's been pruned, and that's because angiotensin levels are very high and there's a lot of constriction, so the blood can't get out to the periphery. And when that happens, you start getting infarcts. So the yellow arrows point to areas where things are dying. And this is where the glomerulus lives, is right at that intersection. So they are starting to die. So scleroderma renal crisis occurs in about 10% of scleroderma patients in the United States. Most of those, or 90%, will have widespread skin thickening. And usually within the first 5 years is when people are most at risk. Early diffuse. The level of blood pressure during renal crisis is usually high, but not always. About 10% will have normal blood pressures throughout the course. Now sometimes there's kind of a saying, sometimes when you're up to your ass in alligators, it's hard to remember that your initial act was to drain the swamp. So sometimes you lose sight of what's happening. I mean, as a doctor, somebody comes in with kidney failure, early kidney failure, and new high blood pressure, and they have scleroderma, and they don't add them all up to realize that they're dealing with scleroderma renal crisis. So sometimes it's missed for a while, so that's bad. And then if you make the diagnosis or even suspect it, an ACE inhibitor, angiotensin converting enzyme inhibitor, is the treatment of choice. Okay, so there's kind of review. New onset high blood pressure, declining kidney function, even to the point requiring dialysis. And if these people are not treated with an ACE inhibitor, 90% or 95% will die within the year. Before we had angiotensin converting enzyme inhibitors, first one was captopril, introduced in 1980. Before that, people died awful, terrible kinds of death. Now that we have ACE inhibitors, we're not out of the woods, but we're a lot better than we were before 1980. So here, let's kind of review now that we've introduced the topic of renal crisis, about 20% in the United States, and it's usually in the diffuse group, widespread skin thickening, and occasionally the limited. Central hypertension, 10 to 12%, proteinuria, about 3%, 15% elevated creatinine in diffuse, and 8% in limited. These are not usually at high levels. 1.5 might be an example. The normal varies from lab to lab, but it's usually around 1.1 or 1.2. If it goes above that, it's said that you have chronic kidney dysfunction. Most of the time, it doesn't go anywhere. All right, so here is a diagram that kind of puts what I just talked about. Maybe it'll be a little easier to hang on to. So the liver makes this protein called angiotensinogen. It gets out into the bloodstream. The kidney normally releases some renin all the time. In renal crisis, it's a lot of renin. And that changes in angiotensinogen to angiotensin 1. That's not a vasoconstrictor. The next step makes it a vasoconstrictor. So it goes through the lung where this enzyme called ACE, angiotensin converting enzyme, lives, and it activates it to angiotensin 2, and that's the beast. This is what causes the trouble. That leads to vasoconstriction, which leads to high blood pressure and kidney failure. So what are some of the factors that would predict that somebody might be at risk? Well, diffuse skin thickening, a fairly rapid progression of skin thickening, and that often is what happens in diffuse. Skin thickening may start out looking like it's just swollen fingers and hands, and then 3 to 6 months it crawls up your arm and then affects your face and your torso. Early disease, less than 4 years. There's a blood test called anti-polymerase III antibody. So in the United States, people with scleroderma that have this antibody are at about 30% risk of kidney failure. So this is an important thing for us to be looking at early, first visit. We need to know what your SCL70, anti-centromere, and your anti-polymerase 3. These are the 3 antibodies that are easy to get in the clinical lab. New anemia can be a sign. A large amount of fluid in the pericardial sac, heart sac, episode of congestive heart failure, the use of cortisone, prednisone, Medrol. Contractures of large joints just reflect how severe the skin is, and that's the predictor. And many people can't get their fingers in their mouth. That sometimes can be a predictor as well. But all this occurs early. All right, so the clinical features that we see as doctors are high blood pressure most of the time, rising creatinine all the time. Some will have a fit or a seizure. People will report new kinds of headaches. There's no particular kind of headache, it's just a new one. You're not used to it. Pressure in the chest, congestive heart failure, increasing skin swelling, so there's a lot of widespread skin thickening. The red blood cells are falling apart. And the reason they fall apart is they go through this clot in the kidney, and that fractures them. I'll show you an example in a minute. Low platelet count, about 40%. Large pericardial effusion, or a large amount of fluid in the heart sac, about half the time. Okay, on the left-hand side, this is a blood smear. This is kind of an old technique now. There's a computer-driven analysis system that allows blood to go through it and no one looks at it. The numbers come out. In this case, we ask them to make a smear and actually look under a microscope, because what we're looking for is on the right-hand panel, and they're pieces. The light blue arrows show you some. Helmet cells, fragments, schistocytes are all terms that would indicate that the blood is being fractured. So the red blood cell is losing its normal round donut shape because it's being clipped, and it's felt to be due to the vasoconstriction in the kidney. So ACE inhibitors, there are now a dozen or more, are the real answers to this problem. These are some of the names, and they should be in your handout. Okay, what happens to people who have renal crisis? Meaning dialysis or death, or what are the outcomes that we're looking at? Well, this is from Steen in Pittsburgh, so it's a United States study. No dialysis 38% of the time. Some dialysis about 40+%. That's about evenly developed into those that are on it temporarily, in contrast to those that are going to remain on dialysis forever. And unfortunately, about 19% die. They just have overwhelming organ disease, and they die. Now this is the Steen. The temporary dialysis generally recovery begins within the first 18 months. Some people are lucky, it's 3 months. Sometimes it's 2 weeks on dialysis, others it's 12, 18 months. All right. Then there is the English experience. The outcomes don't look as good. Whether there's something different they're doing or whether the people in Britain are different, there's a clear-cut ethnicity to renal crisis. Asian countries have a very low risk, and the United States has a high one, so does Britain, about 15 to 20% of diffuse, whereas in Asia it might be 1 or 2%. Okay, so here we have no dialysis, that's about a third. Then we have temporary dialysis, 23%, and permanent, 41%. And again, about 18% die early. The temporary dialysis in this study occurred within 24 months. So 2 studies, one 18 months, one 24 months, probably not much different. And the French have a slightly different take on it. No dialysis is about the same, it's about 40%. Temporary and permanent are about the same, 16 and 22%. And again, early deaths are about 20%. So there's something about ethnicity, I think, that plays a role here. Could be differences in treatments as well. Okay, Virginia Steen has been collecting data on 3,000 patients for over 30 years. They're all in her computer. This is a demonstration of survival, people who live through the dialysis and the renal failure. So if you're on an ACE inhibitor, you have a greater than 70% chance of living a year. If you live a year, you're likely to live 5 years. On the other hand, if for some reason somebody didn't pick up on it and they didn't start the person on ACE inhibitors, this looks like what I saw before captopril. About 90% die within a year. So it's really important to make the diagnosis and to climb all over it. Now, one question that comes up, and we now have at least one answer to the question, can we prophylax against renal crisis? We have some idea of who gets it. So early diffuse. Is there some way that we can prevent it? There's no way to predict it for sure in a given individual that you will get it and you won't. Okay, Canadian Scleroderma Research Group undertook a study that was carried out on the internet. The question being asked was, are people with scleroderma who are exposed to ACE inhibitors prior to the onset of renal crisis at greater risk of worse outcomes compared to those not on these drugs prior to the onset? So somebody was treating mild hypertension most of the time with an ACE inhibitor. So the question was, do the people who get ACE inhibitors before they get renal failure do better or worse than those that waited until the renal crisis came and then we gave them the ACE inhibitors? So this was a worldwide kind of study. Almost 600 physicians throughout the world participated. Every second Friday, Marie Hudson would send out an email that says, have you seen a new patient with renal crisis? If you said no, you didn't hear until 2 weeks, and then you got the same question. If you said yes, then you got to fill out more forms. But it wasn't as arduous as some of the studies that we get involved in. It was fairly focused on a few things, so it was a reasonable request. So data were collected on exposure of patients to ACE inhibitors prior to the onset of renal crisis. The primary outcome was death and or dialysis at 1 year after the onset of renal crisis. So it's a year-long study. What happens in that year? So of 87 patients who were recruited at baseline, 76 we were able to track, so about 87%. You always worry about people who are missing. You don't know what happened to them, so it really taints sometimes what you're trying to say. All right, so what she found was that if you combine the outcomes of death plus and or dialysis, it was about 60% at 1 year, regardless of whether you had not been treated prior with angiotensin converting enzyme inhibitors or not. The use of an ACE inhibitor before the development of renal crisis increased the chance of dying by 2 times. Compared to those who were not treated prior to their renal crisis. This is a study. So it's risky to base everything on one study, but personally, I do not put people on ACE inhibitors who have early diffuse skin disease. Now, she also found that there was a slight increase of death in people who with renal crisis who were treated with prednisone. We can argue from several different studies how much prednisone is safe and how much isn't. Ginny Steen thinks that lower doses, less than 15, are safe. I was part of a study that said 7.5 was dangerous. So there is not a clear-cut answer, but I personally try and stay away from prednisone in early diffuse patients. Okay, a more recent event has been something that we call vasculitis of the kidneys. It's not a blood clot, it's inflammation of the vessels, and they get swollen, and well, the swelling shuts off the blood supply. So you can run into kidney failure with this. Now we know that about 10% of people with kidney failure have normal blood pressure throughout the course. So a new blood test about 15 years ago is something called an ANCA. I don't know that any of you would know what that is. It's an anti-neutrophil cytoplasmic antibody. It has revolutionized our concept of inflammation of blood vessels throughout the body. People who have a positive ANCA are likely to have a set of clinical manifestations that, along with the blood test, suggest that they have inflammation. Maybe not just in the kidney, but elsewhere, along other parts of them. So the contrast here is, this is renal crisis. It's seen predominantly in early diffuse. It's characterized by accelerated hypertension, meaning it went up pretty quick. Kidney failure, 100%, if not treated promptly with ACE inhibitors. Some people will leak protein for the rest of their lives, and some will have a few red blood cells. If that's all it is, that's fine. And evidence of broken blood cells is present. And high renin levels. We have trouble measuring renin directly, or you can do renin, but it doesn't tell you whether angiotensin-II is activated. So trying to measure these has been difficult. Now, vasculitis of the kidney is something that occurs in a different spectrum of people with scleroderma. It's limited scleroderma that's been around a while, in contrast to early diffuse. They have normal or high normal blood pressures. They don't get the 220 over 130. They do quietly get kidney failure, and they have significant protein that comes out in the urine. And there are a lot of inflammation cells and blood cells in the urine as well. They don't break apart their red blood cells, so it's not hemolytic is the term. And the platelet count is normal. Now, kidney biopsies have been done in these people, and let's look at the lower. The upper, on the lower panel, the upper part is what the glomerulus looks like on a slide of a kidney biopsy. So that's the normal part. The part down below is all filled with inflammatory cells and other things that kind of shut off the circulation in that part of the kidney. And in the upper panel, there's a lot of the same kind of stuff. So sometimes the term crescents, meaning like a new moon, or segmental glomerulonephritis is what the pathologist would call it. Now, it turns out that even though this is an immune-mediated disease, it's different than the immune-mediated disease that most of the rheumatologists know about, and that's lupus. People with lupus make all kinds of antibodies to all kinds of things. And they collect in the kidney, and you get this, what is called lumpy, bumpy kind of appearance. It's not a smooth appearance. There's another disease, which is rare, called good pastures, where they have a thin deposit of these antibodies. So that's different than lupus. Then the third one is, there's not positive at all when you do immunofluorescence. So these are the ANCA positive patients. They don't have antibodies that show up in the kidney. Now, there are a couple of immunofluorescent patterns in the blood cells. One is called cytoplasmic, which is the left panel. So the insides are kind of all generally green, apple green. And on the right-hand panel is something called a peripheral, where you see a black dot, which is the nucleus, that's the brains in a cell, and the antibodies are collected around the nucleus. That's a peripheral, or P-ANCA. And that's the kind that are seen in scleroderma, sometimes. So here we have the contrast between the ANCA positive, that's the late limited, compared to the renal crisis, which is the early diffuse. There are ways to tell them apart, and we can do a pretty good job of figuring out what's bothering people with scleroderma and kidney failure. Well, if you go beyond the 18 to 24 months, you are considered chronically on hemodialysis or peritoneal dialysis probably for the rest of your life. Late December last year, I wound up in the hospital with a bad heart rhythm, and I wound up on dialysis for 4 weeks. It sucks. So, how long should we be letting people stay on dialysis before we decide to transplant them? Well, in the past it's been 18 to 24 months. There's several of us that would argue let's start thinking about this at about 6 to 9 months into dialysis. So here is one organ sharing outfit called the United Network for Organ Sharing. They have a database of people that are transplanted for all kinds of different diseases. They had 260 scleroderma patients in this study. And the overall mortality at 5 years was about 27%. The recurrence rate of renal crisis was very low, and most of the time it's because they're still on ACE inhibitors. So anybody that's been through renal crisis needs to be on an ACE inhibitor or another one called an angiotensin receptor blocker, probably for the rest of your life. So this is the 5-year graft survival. It's not as good as general run-of-the-mill renal transplants, but having seen a few people who have had transplants, and even if they fail, they've usually gotten a couple of years off dialysis, and they will tell you it's worth it, and I will go back and try and get another transplant. So at 5 years, 57% are still functioning. The graft is still functioning, which means almost a half have lost their function. The causes of why it failed, only 2/3 did the registry tell us what was what caused it. Chronic rejection, that means the immune system has gotten the better of you and is trying to destroy the transplanted kidney because it's foreign. There are other reasons why sometimes people will have high blood pressure that they need to have treated and they don't get treated, and they may quietly go into renal failure again. Acute rejection, primary failure means the surgeon didn't quite get it right or there was a leak somewhere. Overall, in this study, 7% had a recurrence of scleroderma, renal crisis, 3 infections, and 4% graft thrombosis. And unfortunately, 1/3 unreported causes. All these unreported causes are very troubling to people who look at data like this and say, what's the truth? Why am I missing 30% of these people? Unfortunately, that's life. So, management of kidney issues. The chronic kidney dysfunction is something that quietly happens, usually doesn't go anywhere. You may have a slight rise in creatinine. You may have what looks like essential hypertension that needs to be treated with the usual antihypertensives. If somebody has gotten through 5 or 6 years with diffuse and has not had renal crisis and they get what looks like essential hypertension, I might consider using ACE inhibitors, or I might say there are 5 other things I might use. Nifedipine, hydralazine, there are a whole bunch of things that we have available. Proteinuria, the rheumatologist will say, we'll just watch this. If you go to a nephrologist, they will put you on ACE inhibitors because protein in your urine is bad for you. Elevated creatinine, 1.5, let's say. Generally, you observe and you avoid things that might injure the kidney, and a common one in people that hurt are the anti-inflammatories. So Advil, Aleve, naproxen, all those anti-inflammatories, probably better to avoid them if you can. In renal crisis, ACE inhibitors, when it happens, before that, home blood pressures in early diffuse, 3 times a week, keep a record. If it starts to go up, you need to repeat the blood pressure again that day. If it's still up over 140 over 90 or 150 over 90, you need to get on the horn and get a doctor to prescribe an ACE inhibitor. And you have a list of the ones that you should ask for. Vasculitis of the kidneys, generally this is different. Prednisone and a medicine called Cytoxan or cyclophosphamide is a strong anti-inflammatory. Chronic kidney failure, the real answer is renal transplant, maybe before 18 months. And on that note, I will end.